proceed with the lecture on age-related cataracts. This is our clinical center in Bethesda at NIH, and you're welcome to contact me if you'd like to visit, and I'll show you around. And I'll be talking about age-related cataract, pathogenesis, and potential therapies. Cataract blindness is global, so no race is exempted, and it is accepted as part of aging. 50% of all blindness is due to cataract, several magnitudes higher than the closest one is glaucoma at 8%, higher than all the other diseases of the eyes. And the current treatment is cataract surgery, which requires expensive equipment and skilled surgeons. As you see in this map, 90% of those who are blind live in developing countries, and 80% can be avoided or cured. 65% are 50 years or older. And if you compare that to these global cataract surgical rates, you could see that where the blindness is highest, there's also the lowest rate of cataract surgery. So there's a disconnect between the supply and the surgical supply and the need. It's interesting that India has a high rate of surgery because of the efforts of the Indian surgeons. So 9 million cataract surgeries are done every year worldwide, 3 million in the US. And in developing countries, complication rates can be quite high. In the US, it's the most reimbursed procedure by Medicare, and by the year 2030, there'll be 40 million Americans with cataracts. So in the US, there are 6,500 cataract surgeries per million per year. In India, 5,000. South America, 1,000. China, surprisingly, has low rate because the residency program of ophthalmology is different from ours, and less than half of Chinese ophthalmologists actually perform surgery. In Africa, there are countries where there are only 10 ophthalmologists in the whole country. And in developing countries also, cataracts develop sooner. And in India, there are 6 million blind from cataracts, with 1 million new cases every year. In India, 12 million are blind and 4 million new cases. There's no FDA-approved anti-cataract drug, so there's a need to develop an alternative. In the US, as you can see, there's an increasing incidence with cataract. It's an aging disease, age-related disease, and by 2050, there's going to be almost 50 million cataract cases in the US. So what to do? There are model cataract surgery projects around the world. In China, it's spearheaded by Dennis Lam, who's also now a congressman in China. In the Himalayas, Geoff Tabin, and in India, Dr. Venkataswamy and his Aravind group. But the problem is there are more new cases per year than they can be operated on. So there's not only a backlog, but an increase in the number of cases per year. So there's really a need for an alternative solution. And the first question is what causes cataracts. This is just to show you one of the methods we use in the lab to test anti-cataract drugs, tissue culture of whole lenses. In this case, we were testing temple 8s, and it was able to prevent cataracts due to oxidation. There's 1 millimole of hydrogen peroxide that caused cataract here, and this was prevented by temple 8s. So what are the three major types of age-related cataract? There's the nuclear, because of the opacity in the nuclear area of the lens, and it is the most common. Posterior subcapsular is only less than 10% of all cataracts, and it's like a bullseye becoming larger. And cortical cataract is the best kind of cataract because it spares the central area to the end. So just to briefly go through what we believe is the pathogenesis of cataracts in general. So for nuclear cataract, when you examine the specimens in the lab, what we see is protein aggregation. The proteins clump and cause clouding, and this is mainly because of oxidation of the proteins. Risk factors that we know of: UV from sunlight, cosmic rays, smoking, alcohol, hypertension, trauma and eye surgery, high myopia, poor diet, aging. As you age, you decrease your defenses, and genetic predisposition and obesity. We go to cortical. You see the spokes here, the opacity. And when you look in the lab, you see ionic imbalances. There's swelling and damage of the cell membranes causing these opacifications. And the cause is osmotic stress and oxidative stress. So risk factors, we know, sunlight, UV, diarrhea, dehydration, makes sense because of osmotic stress. Poor diet, again, aging, systemic disorders like hypertension and diabetes, genetic predisposition, and obesity. And that's the posterior subcapsular cataract. When you look in the lab, what you see is toxic damage to the developing cells, so that instead of being laid down clearly and nicely, the cells migrate to the posterior subcapsular area where there's a potential space. And it's caused by toxic or injurious agents and oxidative stress. So risk factors include ionizing radiation, steroids, and other medications. When you develop, it takes high-dose steroids to develop cataracts and glaucoma. Retinal degenerations like retinitis pigmentosa, smoking, high myopia, trauma and eye surgery, and systemic disorders like diabetes. So in summary, you have these three predominant factors: nuclear oxidative stress, cortical osmotic stress, and posterior subcapsular toxic agent exposure. So it's a multifactorial disease. But a common pathway, in the end, all of them lead to clouding of the lens because of protein aggregation. Let's talk about dense proteins and the molecular biology. The lens actually is like a pill, protein pill. It has the highest concentration of proteins in any tissue in the body. And it's made up of crystalline proteins, alpha, beta, and gamma, that make up 80 to 90% of the total proteins. They're transparent. They allow transmission and focusing of light. One of these, the alpha, was recently found to be a special type of protein acting as a molecular chaperone, which protects the other proteins from aggregating. So it's essentially the built-in anti-cataract agent. Just a review of the gross anatomy of the lens. So the lens is like an M&M. It's actually the size of an M&M, except it's clear, transparent, and the oldest fibers are in the center. So the newest fibers are grown outside, and they get compacted into the center as you get older. And again, the alpha crystallines make up 33% of water-soluble proteins. It's a molecular chaperone which protects the beta and gamma crystallines as well as the other structural and enzymatic proteins. So it is an artist's rendition of it. What happens is, as the other proteins get damaged, the tips unravel and become sticky. So the tips of the damaged proteins stick to each other and form high molecular weight aggregates that become cloudy and cause the cataract. So these holes actually bind the tips that are unraveling, preventing them from sticking together, and so it prevents cataract formation. But then if your supply is used up, then there's nothing to prevent cataract. In the lab, we get the lenses, we grind them up, and look at the components in the with various techniques. This is an example of it. Using two-dimensional gels, we can make a map of all the proteins and study them in clear and cataractous situations. So these are all your alpha, beta, and gamma crystallines. We separate them by molecular size in Daltons and also by charge with pH. These are the structural and enzymatic proteins here. But we can't do that in patients. So in patients, we have to find a way to study them without taking them out of the eye. So we partnered with NASA. And why would NASA be interested? It's because with the mission to Mars, it takes years to go from the Earth to Mars. And along the way, cosmic rays will cause cataracts in these astronauts. They become blind. It could be a one-way trip for them, unfortunately, if they do not have countermeasures. So NASA was interested in finding a countermeasure to prevent their astronauts from going blind from cataracts. And so there was a physicist in NASA who had a specialized probe dynamic light scattering probe that could study lens proteins. So he was studying crystallization of proteins in the space station using this tiny probe. Dynamic light scattering was actually started by Dr. Benedek in the 60s at MIT. And a long time ago, they provided me with one of the early machines, but it was huge. It occupied the whole room, and we could not go to the same location again and again, whereas this one is a very tiny probe. So we partnered with Dr. Ansari, who was the physicist, and attached this probe into a keratoscope, which we use for mapping the cornea in LASIK surgery. So we mounted it on the keratoscope and programmed it so that we could obtain 5-minute sampling of the Brownian movement of particles in the lens. And this would be detected by a detector unit and converted into a correlation coefficient by in one of the computers. And from that, we could actually derive a bimodal distribution of the particle size of all the proteins in the lens. We found out in animal work that the first peak is actually the alpha crystallines. So now we have a way to study alpha crystallines, and this second peak actually are the high molecular weight aggregates. So this is the picture of the machine, and it is, again, an example of the output. So we developed the alpha crystalline index, which is essentially the first peak with the alpha crystallines in patients. So first we tested this device and the system in animals, and different cataract models were used. Hyperbaric oxygen in the guinea pig, selenium in rats, diabetics in rats and dogs, radiation in rabbits, Philly mouse, congenital cataract. And in all of this, the DLS detected the changes in cataract much sooner than slit lamp and photographic and lens imaging methods. We used the Scheinflug, and it beat the Scheinflug. So we decided to use it in patients, and in hundreds of eyes, we looked at the alpha crystalline index and compared it with slit lamp examination results, and we found, amazingly, with very high statistical significant levels, that there's a decrease, associated decrease in alpha crystallines with cataract formation. And we also found that there was a decrease as you age. So these are all clear lenses with no cataract, and the alpha crystallines also went down with age. But then it could detect the difference between aging change and cataract change. So this is a group of patients in the same age group, and it was able to differentiate the ones that had cataract compared to aging. So in summary, the DLS detected loss of alpha crystallines in nuclear cataract and with aging. It also can detect early pre-cataractous lens changes and can serve as an early alarm system for oxidative damage. So it's useful as an outcome variable in clinical studies, like in clinical trials in the future. So a measure of remaining alpha crystallines in the lens reflects the level of protective reserve, similar to creatinine clearance in reflecting renal reserve in the kidney. So there were two recent studies that also did a similar thing at Wilmer and at Tokyo that confirmed the results of that big study at NIH. So at the Wilmer study, there's also a significant decrease in ACI as cataract progresses, and there's also a decrease in the alpha crystalline with aging. And in the Tokyo study, these were mainly 30 younger patients, but with the Pentacam Scheinflug, it showed it still picked up the significant decrease with increase in opacity. And the same thing with age. So with aging, there was a decrease in alpha crystalline. So we now recently finished a longitudinal study of cataract. For example, in this eye, this patient came to me because he had some distortion, which probably the visiometrics system of our next speaker will easily detect. But he could not get any straight answer from a lot of ophthalmologists because this was very slight. and it looked normal. So I followed him over 1 year. In 1 year, this disappeared. The alpha crystallines disappeared, and the cataract was there. So we did this longitudinal study at Wilmer, and these are my co-authors there. Studied 66 eyes over 2 years, and again, we used the grading system and Pentacam and the DLS device. We divided the patients into three tertiles into three, ones with low alpha crystalline, middle, and higher alpha crystallines. And we found that those who started with low baseline alpha crystalline, so most of their alpha crystalline was already gone, they progressed very quickly. Whereas those who had high alpha crystallines, this probably reflects aging change. And these are different age groups. So these are the 50 and these are 70. So each age group had a decrease over time of alpha crystalline, and this probably reflects what we saw in the cross-sectional study as the aging change. Those with the lowest baseline also had the highest risk for cataract surgery. So the lower your alpha crystalline, the higher risk for cataract surgery. And this is another patient, started with relatively clear lenses, but with a lot of distortion, and later on developed the cataract, so the ACI dropped to 0, and here dropped to 1. So in summary, it detects alpha crystalline loss in the same eye as the cataract progresses. Those with the lowest ACI develop cataracts fastest, and those also had the highest risk for cataract surgery. And subjects with decreasing ACI over time also had the fastest cataract progression. And we did another study to look at the distribution not only in the nucleus but in other compartments of the lens. And we found that the ACI was highest in the nucleus, next in the anterior cortex, and lowest in the posterior cortex. With aging, in all the components and compartments, there was a significant decrease. So this was in the anterior cortex. With aging, there's a decrease. In the nucleus, as we know, there's a decrease, and in the posterior subcapsular area, there's also a decrease. And we also did a group of young people from 77 to 22 years of age, and we were surprised to see that at that young age, there was a big distribution, a wide distribution of alpha crystallines, meaning you're probably born with X amount. So if you're born with a low amount, you'll probably develop cataract sooner. You'll have less protection. So this may be one of the reasons for the genetic variability, the genetic predisposition of some patients. So how I guess, for practical purposes, how can we avoid cataracts right now? So you address the risk factors. Avoid having diarrhea or getting sick. Avoid UV by wearing UV sunglasses. Take antioxidants. Problem with most antioxidants is they don't get into the lens. They get absorbed, but because the lens is avascular, it doesn't get to the lens. And promote your general health so that your defenses will not go down. And monitor and maintain your alpha crystalline reserves. So most people ask me, how can we increase our alpha crystalline content of the lens? I guess we'll talk in a minute. So this is a list of potential anti-cataract agents. The first one, highly tested, a lot of papers. It's not clear, and that's because most antioxidants that you take by mouth, the vitamins like vitamin C and E, carotenoids, all the oral antioxidants, the problem is they get absorbed in the body but not into the lens, because the lens has no blood vessels, as I mentioned. So it cannot get into the lens. So we're developing nutraceutical agents that are topical, actually, so that it can go through the cornea and the lens without having to go through the gut. These other categories are actually available in many parts of the world, South America, Europe, but and they're to prevent the proteins from aggregating. The problem with them is they do not get through the cornea into the lens capsule, so they don't get into the target tissue, and so none of them have actually been proven in the U.S., so none of them are approved by the FDA. Aldose reductase inhibitors are only good for mainly for diabetic patients because they prevent diabetic cataracts. in animals. We've done a lot of studies, but none of them so far have had clinical trial in the U.S. But I think one of them had a trial in Japan. The Kinostat has been approved for dogs because dogs also develop diabetic cataracts, and it's available for dogs. Multifunctional agents are free radical scavengers and metal ion chelators, and there's a bunch of them being tested in the in animals and in pets. The mini chaperone peptides, these are the how to beef up your alpha crystallins. So because the alpha crystallins are large proteins, they cannot get through the cornea also. But what these groups did, they got peptides that are like snippets of the molecule and delivered as nanoparticles, and they've shown it could get into the lens in tissue culture. So they haven't really done it on live animals or patients yet, but at this point they're doing studies in tissue culture experiments, and this is an example. So there's two groups that are doing this: Srikumar and Hinton from California, and Naomi and Nagaraj from St. Washington Hospital in St. Louis. So they're using PCL nanoparticle delivered alpha B and alpha A crystalline derived peptides. So these are the nanoparticles that are blank, and then these are loaded with the alpha B crystalline mini chaperone, and this is the one that's loaded with the scrambled alpha crystalline. And so these have been shown to, the nanoparticles have allowed the peptides to get into the lens, I mean the cells, and I think they've done it in intact lenses also in tissue culture. So the next step would be in live animals now. Just as a last few slides, another application for this DLS is also as a ACI as a biomarker for systemic oxidative stress damage and aging. Now the lens is encapsulated, as I mentioned, and the oldest fibers are in the central area. So you have your entire lifetime sort of record in the lens. So you could actually examine the lens for ACI and use that as a biomarker for your exposure to different stresses and aging. One of the main theories of aging is that we age because we get burned up, I guess, from oxidation. And this could be and so we're partnering with NASA and DOD to look at damage to the lens. As you know, anemia, muscle fatigue, they all can be caused by oxidation, even neurodegenerative disorders like Parkinson's and Alzheimer's. So I just to show a picture of my coworkers. This was a picture taken when we were given an award for this work by Secretary Sebelius. So this is Sam Ziegler, who's used to be at NIH, now at Hopkins, Deputy Director Tabak of NIH. This is Dr. Ansari from NASA, my main partner. He's an Assistant Secretary of Dr. Sebelius. This is Dr. Stark, from Director of Cataract and Cornea at Wilmer at Hopkins. And Dr. Sheila West is the Assistant Director of Hopkins. Is an epidemiologist and a statistician. And my two fellows, Andrea Zambrano and Ching Pan. So thank you very much. I guess we're on.